Rehab Institute of Chicago has a interdisciplinary pain program, which is quite different than the way most people are presenting and treating pain these days around the country. Our program has been here for 35 years or more, and involves a rehabilitation approach more from the use of PT, OT, clinical psychology, biofeedback. We work on teaching people relaxation techniques, ways to decrease their pain while trying to increase their movement patterns, things that would allow them to really go back to more of a functional approach to life. In the principles of RIC and with rehabilitation medicine, we always keep function kind of as at the center point of what we're trying to do. And so as we see patients here, oftentimes we're seeing them when they've either not done well with medicines or had medication problems. They've probably had procedures and injections, maybe even surgeries that didn't really solve the problem for themselves, and they're still looking for a way to help improve their life, decrease their pain, return to their activities that they were doing before, and that's really what we focus on here at RIC. I think that the way we approach pain management is difficult for smaller organizations to do, because to be committed with your team, they have to be busy enough to pay for themselves as they do the amount of treatment during the day, and be able to cover things, and we want a group that's doing nothing but pain. So a lot of places will use some team members, but then they go off and they do other things, and sometimes they treat pain, sometimes they treat other things. It's hard to bring them back when they need them to do more pain management, and so it's a big challenge for them to keep their team together, to keep them focused on treating pain. I think that it's often difficult with the population size of smaller areas. You know, in Chicago, we have a somewhat steady flow of referrals and people coming to our program, so we can keep the business sustained. That's very difficult to do out in rural areas. You might see a couple pain patients one month, not the next month. What do you have those people doing to stay busy, and so you can keep them employed, and that's difficult out in those areas. As we look to the future, I think from RIC's standpoint of how do we try to help with those people in smaller areas and what resources they may or may not have, it comes down to technology. In today's world, can we find interactive videos, teaching methods, perhaps even, I guess, chat groups, and we do group sessions within our program. I know, like, when my daughter was in nursing school, they were doing online group sessions for teaching, so we probably can do those same things with patients. Ways to implement technology are probably going to overcome the need to be on site for a lot of things, and if we put those things together correctly, then the question will be, from a medical side, are they getting the same response? Are they getting the same benefit? Can we show that they would be able to do these things with less cost overall than perhaps what it is now, and still help people and get the same benefit? So that's kind of an unknown, but I certainly think technology is going to be the wave of the future. The National Pain Strategy was released in March of this year. It came out with a description about the problem of pain in America and the cost factor with that. And we hear a lot these days about kind of the cost in lives and things going on with the opioid problems. So the National Pain Strategy came out with kind of a framework of what the hope would be for the future to start educating people, doctors, the general population, medical students as they're going through, to better manage pain than what we're currently doing at this point. I think the emphasis from their standpoint is on interdisciplinary care, where you start to use more things that a person would do to help themselves. commonly called self-management techniques. And I think we see those things popping up on the internet now in different places, not necessarily for patients, but for just all of us in general. But as we get to the focus of how do we manage chronic pain, it is self-management techniques which are going to be a key. Most people don't realize that would be the best way to do it, so educating the general population to know better than it's not just medications or it's not just injections. They really are going to have to put some of their effort into it. Those things, when they put their effort into it, start to change how their brain works and how their body feels, and that's what kind of work we do here. I think we have to educate primary doctors and other doctors to know when a person needs more of that and perhaps not some of the other treatments. Currently, that doesn't go on very much in medical school, and so we need to get out and be able to teach those people to help their patients get to the right place at the right time and to do things. I think those are the key points from the National Pain Strategy. Certainly the background emphasis is that there are a lot of things being done now which aren't terribly successful for people, and some people are on meds that shouldn't be on meds, and some people have had a lot of procedures done that shouldn't necessarily have had them done, and getting the idea that other things are more helpful for some people rather than just doing more of the same things that aren't working. That was one of their other important messages in there. So the National Pain Strategy came out just about exactly the same time as the CDC guidelines on opioid management came out. And so I think the publicity that the CDC guidelines received probably overshadowed the emphasis in the National Pain Strategy of how to go about changing these things. Both documents really emphasize that non-pharmacologic management should be maximized for people to try and help them. It's not just from a medication standpoint. Certainly the CDC guidelines focus on how to start limiting that negative aspect of what might be going on. However, changing the treatment to give people the option to do something other than medications is really the important point. And so in the 6 months since both of them have come out, there's been a lot of discussion about how to reduce opioid management, but there's been very little discussion about how to start implementing more interdisciplinary care, self-management techniques, how to get insurance companies to pay for these things so that people will have coverage to be able to try different things. Unfortunately, many patients end up on medications because they don't have coverage for a lot of other things. And certainly we need legislative and lobbying efforts to change this. I mean, if we're going to consider this to be a social issue for the entire country and really a national health care issue, we need leadership at the top that's going to say, you will cover these things instead of opioids so that patients can get proper pain management and not just focus on the medications all the time. That perhaps would open more opportunities once again for hospitals and other programs to be developed to start to do the things that we do. Once upon a time, a long time ago when I was in training, there were a lot of these programs, but many of them have gone by the wayside due to financial issues and lack of coverage in certain areas. And we certainly need to bring back more programs and cover more people around the country if we're going to have success really in changing pain management and in reducing the opioid issue, in my opinion.